Assalamu alaikum wa rahmatullahi wa barakatuh. Today, our lecture will be about ECG abnormalities encountered in myocardial infarction. But first, we should know term of acute coronary syndrome. And also there is terms related to this topic, the acute coronary ischemia and the acute myocardial infarction. So what is acute coronary syndrome? Refers to a group of a clinical disease occurring as a result of acute myocardial ischemia or infarction. Ischemia, so there is only one type for the ischemia, myocardial ischemia, unstable angina. And if there is infarction, that means there is a cell death or injury. And in this situation, the troponin will be elevated. And this is a case of acute myocardial infarction. There is two subtypes for acute myocardial infarction, non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Also, sudden cardiac death and pulseless ventricular tachycardia, ventricular fibrillation included in a case of acute coronary syndrome. Acute coronary syndrome account for more than 30% of death in the West. Patient who presents with a suspected acute coronary syndrome must be assessed in the ED on an urgent basis, category 2, and have an ECG performed within 10 minutes. And clinician with ECG expertise should review the ECG. Types of acute coronary syndrome, as we said before, acute coronary ischemia or acute myocardial infarction. The case of acute coronary ischemia, this is only unstable angina. In unstable angina, ECG changes may or may not be present. The ECG may be normal in unstable angina, and the troponin will be normal also. The new onset severe anginal chest pain should be considered unstable angina. Also, if there is any change in the frequency or duration or chest pain at rest or with minimal exercise should be considered also as unstable angina. In case of acute myocardial infarction, there is two subtypes, ST elevation or non-ST elevation myocardial infarction. In STEMI, ST elevation will be 1 millimeter or more in 2 or more anatomically contagious leads, except in V2 and V3, there is special characters for V2 and V3. In V2 and V3, you should differentiate if the female or male. In female, the elevation should be more than 2.5 millimeter. In male, if less than 40, the elevation should be 2.5. And in female, more than 40 years, the elevation will be more than 2.5 millimeter. In female, 1.5 millimeter. And also we'll see reciprocally changes in other leads. And we should consider the new left bundle branch block may be included in the ST elevation myocardial infarction. In case of non-STEMI, there will be ECG changes like regional ST segment depression, T-wave inversion or flattening. Any dynamic changes or new Q wave should be considered the non-STEMI. The only way to differentiate between non-STEMI and unstable angina, the troponin will be normal in the case of unstable angina. How to diagnose acute coronary syndrome? Of course, history is very important in this situation, especially the comorbidities of the patient as diabetes, hypertension, body mass index, dyslipidemia, and smoking history. Chest pain, of course, there is a classical angular chest pain. In this situation, the pain will be retrosternal chest pain referred to the back or neck or mandible or both shoulders, and also there is associated other symptoms like nausea, vomiting, or dizziness, maybe syncope. The differential diagnosis, there is many differential diagnoses, but we should consider the life-threatening condition like a case of pulmonary embolism, aortic dissection, or a case of tension pneumothorax or esophageal rupture. And also chest pain and pneumonia and myocarditis considered a life-threatening condition. Cardiac biomarkers, of course, troponin 1 or T or high sensitive troponin will be elevated. The chest radiography, chest X-ray doesn't have a typical finding in acute coronary syndrome, but can provide ancillary information. As a case of aortic dissection, you will find wide mediastinum. A case of congestive heart failure, there is bilateral lung condition and cardiomegaly, or pneumonia, consolidation will be in the chest X-ray. Cardiography, CT angiography, and the echocardiography. In echocardiography, there is wall motion abnormalities, hypokinesia or akinesia. The main topic today is ECG changes in acute coronary syndrome. In the image to the left, this is the finding, the normal impulse in ECG. Start with P wave, QRS complex, and ST segment and T wave. To check the ECG changes in ischemia, you should consider the ST segment and the T wave. And this is the isoelectrical line TP segment, not the PR segment, because PR segment may be depressed in some cases. So the isoelectrical line, we should consider here the TP segment, and this is the ST segment and the T wave. Here the J point is a junction between the S or R wave and the ST segment. And from this site, we will measure the elevation. As in case of the next image, ST segment, elevation, myocardial infarction. This is the J point, and here is the ST segment, and the inverted T wave and the isoelectrical line. J point elevated from the isoelectrical line and also the ST segment. The next image show ST segment depression from the isoelectrical line. Here is the J point and the ST segment horizontal depression. Also, a T wave inversion, it will be symmetrical and narrow base, ST segment depressed from the isoelectrical line. We will talk in detail about the ECG changes. The first change and the earliest change we may see the ST segment, the hyperacute wave. Hyperacute wave characterized by tall and often symmetrical broad-based T wave, seen in early stage of ST segment myocardial infarction. In early stage also may be present or absent. We should consider particular attention also for the previous QRS with the hyperacute wave. As we see here, this is a case of hyperacute wave. The T wave taller than 10 millimeter and narrow base and symmetrical, and taller than the R wave is the same QRS. Here there is elevation, but less than the R wave in the same QRS. So this is not a case of hyperacute T wave, while this is a hyperacute T wave. As we see here in this ECG, the first ECG, in V3 and V4, there is ST segment elevation. There is hyperacute wave here, taller than the R wave in the same QRS, and also there is a hyperacute wave in the V4. The second ECG show the same ECG for the ECG for the same patient 30 minutes after the chest pain and after the first one. There is ST segment elevation from V1 to V4, and this is a case of anterior myocardial infarction. Differential diagnosis for hyperacute wave, of course, transmural acute myocardial infarction, hyperkalemia, repolarization, left ventricular hypertrophy, and myopericarditis. The second change we will see here is the segment elevation. Here we see this is the J point, and there is the ST segment elevation. Usually it will be convex, not like the early repolarization. That one below is a concave. Here is the concavity, and here there is the convex. Also, in a case of pericarditis, it will be horizontal or concave, but the PR will be depressed, not like that one in acute coronary syndrome or STEMI. Also, this is a case of early repolarization. So how can we differentiate between the ST segment elevation in STEMI and early repolarization? First, the clinical context is important in this situation. In early repolarization, the patient will be young adult. and usually there is no past medical history. And also, if you check the ECG, there will be notch at the J point here, especially in V3 and V4, and the elevation, the ST segment elevation will be concave, not like a STEMI convex, and scattered in all leads, not in anatomical location like STEMI. Differential diagnosis for STEMI: acute myocardial infarction, acute pericarditis, left ventricular hypertrophy, benign early repolarization, hyperkalemia, and Brugada syndrome. Anatomical location for STEMI. In this image, we will see there is the blood supply for the heart. There is two main coronaries, left main coronary artery and right coronary artery. Left main coronary artery gives two vessels, left circumflex and left anterior descending artery. In left anterior descending there is several branches, septal branch, diagonal branch, and all of them are important in the location. The right coronary gives many branches, but one of the most important branches, posterior distal artery, which give branch to the AV node. So in common in right coronary artery occlusion or posterior distal artery occlusion, we may say there is degree of heart block. If the changes in lead 2, 3, and AVF, this is a case of here, the changes here. This is a case of inferior myocardial infarction. In V1 to V1, V2, this is a septal wall myocardial infarction. From V1 to V6, this is extensive anterior myocardial infarction. In lead 1 and AVL and lead 1, this is high lateral myocardial infarction. In this table, we will see the location of myocardial infarction and the lead affected. Anterior wall myocardial infarction, the lead will be affected, the affected leads V2 and V4, and the culprit vessel will be diagonal branch. Septal wall V1 and V2, and the culprit vessel septal branch of the left anterior descending artery. Lateral wall in high lateral in lead 1 and AVL, and the lateral in V5 and V6, and the culprit branch will be the circumflex branch. Inferior wall myocardial infarction in lead 2, 3, and the AVF, and in this situation, right coronary artery or posterior descending branch. Posterior wall myocardial infarction, the changes will be clear in V1 to V4, and also if we did the posterior lead ECG, it will be clear. And the culprit branch will be circumflex branch or posterior descending branch of the right coronary artery. The next ECG changes, we will see also ST segment depression. ST segment depression is typically horizontal or downsloping in case of acute coronary syndrome. As we see here, this is horizontal ST segment depression. Also, there is ST segment depression here, horizontal, or maybe a slight downsloping. But in case of upsloping of ST segment depression, as we see here, and the upright in T wave, but the ST segment depression, the upsloping will be below the level of isoelectrical line, as we see here. Here, this is the upsloping of ST segment and the upright of T wave, and the ST segment depression below the level of the isoelectrical line. This is a case, we will see it later in the winter pattern of ECG changes. Differential diagnosis for ST segment depression, the most important, bundle branch block, digoxin effect, and rate-related ST segment depression. In cases of sinus tachycardia, you may see ST segment depression scattered in all leads, but when you control the rate, it will return to the normal. This is a rate-related ST segment depression. How to differentiate between the digoxin effect and the ST segment depression? Here, in digoxin effect, there is a downsloping ST segment depression with characteristic reverse tick. This is a reverse tick or Salvador Dali. This man, Salvador Dali, and this is a sagging appearance of ST segment depression. And also you will find flattened T wave and shortened QT interval in the case of digoxin effect. This is a digoxin effect, not a digoxin toxicity. So it's normal to be found in the ECG on the patient on digoxin. The last change you see here, the inverted T wave. Normally, the acute T wave is upright. So it's normal upright in lead 1, 2, and from lead V3 to V6, and inverted in AVR. Normally, maybe inverted also in V2 and in V1 and V2. T wave inversion of acute coronary syndrome are classically narrow and symmetrical. As in this image, there is a inverted T wave, symmetrical and narrow, and maybe also symmetrically and deep inverted T wave, as in case of Williams syndrome. The differential diagnosis for T wave inversion: ventricular hypertrophy, bundle branch block, hypokalemia, and persistent juvenile T wave pattern, and normal variants. So it's normal to be seen in a normal healthy patient to see the inverted T wave. In children, the inverted T wave in V1 up to V3, it's a normal finding and may persist to the adulthood. Now we'll take some cases about the ECG changes. The first case, male patient, 56-year-old smoker, with complaining of retrosternal chest pain, referred to the neck since 1 hour. In this ECG, we will see there is ST segment elevation in lead 1 AVL, and also from V1 up to V5. So this is a case of anterolateral myocardial infarction, anterior from V1 to from V2 to V5, and the lateral in lead 1 and AVL. This is a case of anterolateral myocardial infarction, and you will see there is a reciprocally changes ST segment depression or inverted T wave in lead 2 and AVF, and the culprit here will be the left anterior descending artery. Case 2, female patient with history of diabetes, hypertension, and body mass index 26, complaining of gastric pain since 3 hours, vomiting once with nausea. So there is other associated symptoms with the chest pain. Vital signs: the systolic blood pressure 80. This patient is hypotensive and complaining of dyspnea with hypoperfusion. So the patient in cardiogenic shock. The finding in ECG, we will see here, there is ST segment elevation in lead 2, lead 2, lead 3, and AVF, and with reciprocal changes in lead 1 and AVL. This is a case of inferior myocardial infarction. But if you look to the V2, there is ST segment depression with inverted T wave in V2. If you find this case, you should consider right myocardial infarction. And also there is the ST segment elevation in lead 3 more than lead 2. Also, this finding help to diagnose right myocardial infarction. And in this case, we should do right coronary, right ECG leads. The culprit here will be the right coronary artery. This is inferior myocardial infarction with right myocardial infarction suspected. The third case, 52 years old, male, hypertensive smoker, previously well, 1 hour of central chest pain radiated to the back, and blood pressure 80/45. Patient also hypotensive. In the ECG, there is widespread ST segment depression in all leads with ST segment elevation in AVR. There is widespread ST segment depression in all leads and elevation in AVR. And this is a serious situation, because if you see this criteria in ECG, that means there is a serious condition maybe there is left main coronary artery occlusion or triple vessel disease, and this patient need immediate intervention. Case 4, 48 years old male came to the ER with acute chest pain. If you see the ECG, there is a criteria of maybe there is ventricular hypertrophy, as we see in the precordial leads here. There is left ventricular hypertrophy. So this is elevation. This elevation in V2 may be significant or may not, also in other leads. But in lead 1 and AVL, there is a considerable ST segment elevation in lead 1 and AVL, and also in V2. This is a case of high lateral myocardial infarction. And if you see, this sign is a South African flag sign. As we see in this image, here the South African flag sign, and the elevation will be in lead 1, AVL, and V2. This is a criteria for diagonal branch, this branch from the LAD, diagonal branch occlusion. The next case, middle-aged patient presented with central chest pain. If you look to the ECG, there is S-segment elevation in lead 2 and AVF prominent. Also, there is ST segment depression in V1 and V2, maybe V3 and V4. Also, there is elevation in lead 1 and lead 5 and V6. So this is a case of inferior myocardial infarction and lateral, infralateral myocardial infarction. And there is ST segment depression from V1 to V4. And this is a criteria for posterior myocardial infarction, ST segment depression with upright T wave. Here, this is the ST segment depression from V1 to V4 with upright of the T wave positive. So you should suspect the posterior myocardial infarction. The evidence of infralateral myocardial infarction in this case, ST elevation, infromyocardial in V2, V3, and the AVF, and also ST elevation in lateral leads, lead 1, V5, and the V6. And the evidence for concurrent posterior STEMI, the horizontal ST segment depression. This is a horizontal ST segment depression, and the dominant R wave in V2, also upright T wave. This criteria, you should suspect posterior myocardial infarction, and in this situation, we should do posterior ECG leads, V7, 8, and 9, to confirm the diagnosis. One of common trick to turn the ECG, تقلب ECG and تبص عليه من الخلف، ترفعه على لايت وتبص عليه من الخلف. كده ممكن تشوف في V2 and V3 the criteria for ST segment elevation myocardial infarction. And as in this image, if you flip and return it and elevate it to the light, you will see this image, and you suspect the posterior myocardial infarction in this case. A 6-old male came to ER with a chest pain and epigastric pain and vomiting. In this ECG, there is ST segment elevation in lead 2, lead 3, and AVL. And in this situation also, the elevation in lead 3 more than elevation in lead 2. And you will see there is ST segment depression in V2. This is a case of right myocardial infarction. In this situation, if the elevation in lead 3 more than lead 2 and ST segment depression in V2, you should suspect right myocardial infarction, and we should do right precordial leads. Also, there is reciprocal changes in lead 1 and AVL. A case of inferior myocardial infarction with right myocardial infarction. So in patient with inferior myocardial infarction, you should suggest right myocardial infarction with, if there is ST elevation in V1 or ST elevation in V1 and ST segment depression in V2, or isoelectric ST segment, يعني normal ST segment in V1 and marked depression in V2, and the ST elevation in lead 3 more than lead 2. In this situation, we should do right precordial leads, and the most useful to diagnose the V4 right lead. Clinical significance of right ventricular infarction. Why you should suspect or diagnose right ventricular infarction? Because in this situation is very sensitive to the prelude. If the prelude dropped, this patient will be a refractory hypotensive. So there is contraindication in this case to give nitrates because it will drop the prelude and the patient will be refractory hypotensive. And if there is hypotension in this case, you can give a fluid to treat the hypotension in this situation. Case 7, old female with acute chest pain. Here we will see there is a hyperacute T wave in V2 up to V4, and also there is ST segment depression with down sloping, as we see here. Here in V3, there is ST segment depression with upsloping, and the sloping of the SCT here is below the level of isoelectrical line. As we said before, this is a case of D winter syndrome. D winter, there is hyperacute wave and ST segment depression with upsloping, and the sloping below the level of isoelectrical line. And also there is reciprocal changes in V3 and VF. This is a serious case and should be considered as anteromyocardial infarction, because the occluded nerve, the occluded vessel here will be the left anterior descending artery, and this patient need immediate intervention. This is a D winter pattern of ECG. So what is a D winter pattern? Upsloping of ST segment depression in the precordial leads more than 1 millimeter at the G point. Here the upsloping of ST segment depression, and peaked anterior T wave. The T wave in the precordial leads from V2 to V6 is peaked with ascending limb of the T wave commencing below the isoelectrical baseline, below the level of isoelectric, and subtle ST elevation in AVR more than 5 millimeter. So this is a case of the winter pattern and is considered as anterior STEMI and require immediate reperfusion therapy. Case 8, 57-year-old woman presented with acute chest pain. Here there is, if we see in the precordial leads V1, V2, V3, and also V4, there is a biphasic T wave. The first one is the first part upright, and the second part down inverted. If you see this image in biphasic T wave from V1 to V4, this is a case of Williams syndrome, and also this is an urgent situation, and they need immediate intervention. So this is a case of Williams syndrome. When you suspect Williams syndrome, a clinical syndrome characterized by biphasic or deeply inverted T wave, as we see in this image. T wave may be biphasic, and the first part upright, and the second part inverted, or deeply inverted, symmetrically inverted T wave in the precordial leads from V2 to V1 to V4. This is a case of Williams syndrome. It is highly specific of the left anterior descending artery. So the patient may come with of pain. In between the attacks of chest pain, the patient of pain, and you find this changes in ECG, and this is a critical situation, and the patient need immediate intervention because there is a critical stenosis in the left anterior descending artery. So there is two types of Williams syndrome: deeply symmetrically inverted T wave or biphasic T wave in the precordial leads from V1 to V4. Case 9, a 62-year-old male with a history of acute chest pain. If we look to the ECG, there is a criteria for left ventricular left bundle branch block. Here is the criteria for left bundle branch block in right precordial leads V1 and V2. You may see there is wide QRS and QS pattern or small R wave. And also you will find there is a wide R wave in V6 here. There is QRS, wide QRS with inverted or stream pattern, inverted T wave here, and also in V5. This is a criteria for the left ventricular hypertrophy. So if there is chest pain, we should consider the Scarboza criteria. What is the Scarboza criteria? We will discuss now. The Scarboza criteria for diagnosis of acute myocardial infarction in cases of left bundle branch block, there is three criteria. A concordant ST segment elevation more than or equal to 1 millimeter, it gives 5 points. So there is concordant changes and discordant changes. What is concordant? Concordant mean that the elevation in the same direction of QRS. If the QRS is positive, so the direction will be positive, the elevation will be positive, or the QRS depressed, the ST segment depression in the same direction. This is a concordant change. Discordant, that means the direction of elevation against the direction of the QRS, or the net result of the QRS. Here there is ST segment elevation in the same direction or concordant ST segment elevation. If more than or equal to 1 millimeter, this is a significant elevation and it takes 5 points. Also, ST segment depression more than 1 millimeter, more or equal to 1 millimeter, as in this case, this is a concordant ST segment depression. It takes 3 points. And in case of discordant ST segment elevation, the opposite direction for the QRS, if more than or equal to 5 millimeter, it takes only 2 points. So even if you see these changes, it is not diagnostic for the myocardial infarction, because you should only diagnose acute myocardial infarction if more than or equal to 3 points. So this is if the only change in the ECG, it is not diagnostic. In this situation, the sensitivity 52 only. That's why Smith modifies this Scarboza criteria and gives us the modified Scarboza criteria. What is the change in modified Scarboza criteria? The concordant changes is the same. If there is ST segment elevation, one or more millimeter in the same direction in positive QRS, or in case of negative QRS, there is ST segment deviation 1 or more millimeter. And the change here is the elevation in the discordant should be more than or equal to 25% from the S in the same QRS or the same impulse. As we see here, if you measure the S wave, it's 15 millimeter and the elevation 5 millimeter. You should divide the ST segment over the S wave, as we see here. 5 over 15 equal 0.33. It's more than 25. This is diagnostic for the acute myocardial infarction. And this is a change. He changed that not only the 5 millimeter, but also you should measure the S wave in the same lead and divide the ST segment elevation over the S wave in the same lead. If more than 0.25, it's diagnostic for acute myocardial infarction. And this raises the sensitivity of diagnosis of acute myocardial infarction in the case of Scarboza criteria. The last ECG here, this is, as we see here, there is a posterior myocardial infarction and there is ST segment depression in V2 with upright T wave in the same lead. And this is a based rhythm, ventricular based rhythm. There is a spark before every QRS. This is based ventricular based rhythm. And there is a case, of course, in this case, there is left bundle branch block, and you will see there is depression in V2. The depression here in concordant, it means the same direction of the QRS and more than 1 millimeter. This is a diagnosis for posterior myocardial infarction in case of left bundle branch block. And this is the last case, and thank you.